Hello, welcome back to the third Q&A session. Here I have Bonnie Crater, Dr. Paul Mead, and Dr. Kristen Honey. Thank you guys all for taking the time. So we have a few questions coming in from the audience. We'll start with this one. I think it's more for Paul. Are there any new Lyme tests that are more reliable than ELISA Western blot?
Very sorry about that. The biggest development recently in terms of Lyme diagnostics is not a fundamental new change. It's really the modified two-tier test, which is again a serologic assay, which has a number of limitations. This particular assay we think performs pretty well and is in some ways sort of easier to deploy and to use and rapid. So that's certainly an advance, but I think we recognize there are needs for quite a bit of additional work, and particularly the development of non-serologic tests, direct diagnostic tests that either are based on molecular assays or on antigen capture assays, or perhaps even new and other things. And I think this has been part of the thrust of what Dr. Honey has talked about in terms of a diagnostic moonshot, and I think that's an important step forward in this regard. But there's a lot of work to do there to develop a reliable direct diagnostic test that will help us know whether a person is currently infected, as opposed to the serologic tests, which really are sort of sometimes after the fact and can remain positive even after a person has been adequately treated. So.
Yeah, we certainly hope to innovate in that realm for within LymeX and the moonshot. I guess another question, a few kind of came in around this issue of low incidence states, and why are cases vastly undercounted in low incidence states, and what is the CDC doing to try to fix this problem?
Yeah, I think, and maybe this isn't clear from my presentation, particularly when it comes to passive surveillance, which is the main thrust of what I was talking about. Cases are always underreported everywhere, and it's not just Lyme disease. That's true across the board for a lot of nationally notifiable diseases. I mean, it's well recognized throughout CDC and I think in public health that the cases of salmonella are underreported, and the cases of syphilis are underreported, et cetera. So it's a broad phenomenon that goes along with passive surveillance. Now, that's why I think we need some of the alternate or additional forms of surveillance that I mentioned just briefly at the end, where we can look at, hopefully in the future, electronic medical records or billing claims or other things to try and get a sense of how much we may be missing. So I want to be clear that I think part of the impression that disease is infrequent or less frequent in some of these low incidence areas is not just based on the surveillance data that comes in from humans. We have looked at other things, including seropositivity in dogs. Dogs all over the country are tested, millions of them, for Lyme disease, including in areas where Lyme disease appears to be rare. Dogs are that correlates well with what we see in terms of human surveillance data. But I think, we do have a challenge in the sense that we know that Lyme disease is spreading and it's emerging into new areas, and to sort of be able to track that leading edge of where it's going from pretty uncommon to pretty common is a key step that we need to be able to look at and trace, so that people can be aware of. I think people in Connecticut know they're at risk, and we need to be able to help people on the boundary edges sort of understand the growing threat and what they can do.
We certainly know we're at risk in Connecticut, I can tell you that. So a question over to Bonnie. The majority of federal research is not focused on projects that address the burden of disease. Majority is spent on pathogenesis and indirect diagnostics, for example, rather than on therapeutics and direct detection diagnostics. How are you making sure that the money patients are fighting for will go to projects that will benefit patients?
Well, the funding landscape has actually changed quite a bit. The funding that questionnaire is really addressing is what's funded in the NIH. But we have lots of programs now across the government that are working on Lyme disease. So we have the CDMRP program, which is a research program in the Defense Department. The House has asked for $5 million to fund the LymeX program, right? The House has also asked for additional $8 million, up 50% for the CDC. To focused on programs. So there's a lot of different types of programs. But if you're talking about the NIH and the NIAID department that really looks after Lyme disease research, that's where the bulk of the money is right now, but it's also changing. The way to implement that is to have more direction from Congress. So if you're interested in making that a priority, please do reach out to your congressman or woman and let them know, there's your congressperson or your senator, and let them know that this is an issue for you. They will listen to you. That's their job. And I've been really, since I started working on this 2 years ago, I've been really excited to learn how constituent focused most of our congresspeople are. And so reach out to them, also get involved in our programs, because we are fighting for the same thing. We want to have more programs funded by the NIH focused on other things besides pathogenesis. The last thing I would just say is that the NIAID or the NIH has a total, I guess, has a strategic plan for tick-borne disease. It's actually quite excellent and emphasizes not just pathogenesis, but many, many other areas. Your congresspeople just need to hear from you to let them know that this is a really important priority for the Lyme community, to ask Congress to make legislation that will ask the NIAID to execute this really actually quite good strategic plan.
And a quick clarification too, does the Center for Lyme Action only focus on Lyme, or do you also working on other tick-borne diseases?
We focus on Lyme and tick-borne disease. Occasionally we have to package it as vector-borne because that's the only way to get it through Congress. However, we're focused on Lyme and tick-borne disease.
Great. Question over to Dr. Honey. You mentioned Kidney X as sort of a model for LymeX. Can you talk a little bit about how Kidney X works and how long did it take? Kind of where are they in the process?
Sure. Kidney X was announced in April 2018. So it's about 2.5 years ahead of LymeX. And it was a big, ambitious kind of use of grand prize challenges to catalyze transformation in kidney care with the ultimate goal, big, audacious stretch goal of having artificial kidneys in human clinical trials by 2024. And again, using the prize challenge model, so only solvers who actually deliver technologies at certain specification will get big purse prize. That has since grown. They've done many, many rounds of challenges, some small, some just announced the first phase winners of the Artificial Kidney Prize. There have been 2 rounds of reimagined dialysis and some small scale patient innovator challenges. And compared to the Kidney X timeframe that we are emulating, we're ahead of schedule actually. It took 2 years before Kidney X was even introduced into the congressional budget at $5 million a year, and we have been introduced 1 year in. So it's not a guarantee that we will get money, but at least it's on the radar of Congress, which is great. We have already done our first round of prizes less than a year into the announcement of LymeX, and that was the Healthathon Education and Awareness Challenge run this spring and summer. So we are fast tracking everything, about 2.5 years behind Kidney X, but following that model because it works so well. And one of the biggest things that Kidney X did that exceeded even our our expectations at HHS was by putting a spotlight in this area. It really unlocked not just government resources and attention, but also private sector. So it was a signal to industry and a signal to all sectors that this is an important area that we need medical investment. We need venture capital investment. We need to get these solutions from lab to market bench to bedside and out to the market as, used by patients as quickly as possible. So I would say we're 2.5 years behind, but hopefully catching up really fast, and it's a great model. And we're lucky to be able to follow in those footsteps.
Great. Another question for Dr. Mead. Why are cases not counted at all in Massachusetts?
Well, that's I'm not sure they're not counted at all, but they're certainly
not reported, I guess is probably what it.
So as I mentioned a bit in my presentation, in some ways, the decision about reporting rests with states, and ultimately states can have their own constraints and decisions that they make about reporting. I think we've been working closely with folks in Massachusetts to sort of work out other ways in which cases can be counted. And indeed, that's part of the impetus behind the new surveillance case definition and approach going forward. I think I hesitate to speak for the folks in Massachusetts, but I think essentially what they would say is that they know they have a problem with Lyme disease in Massachusetts. And the problem in high incidence states, as I mentioned in my presentation, is it ends up being a huge burden, full staff working year round to just count the cases. And at the end of the year, what they know is that they have a big problem. And so I think they want to really try and redirect those efforts towards prevention and things that are going to be more effective from a public health standpoint. And so Massachusetts may have been in some ways leading the charge of really sort of abandoning the old system. But I believe as we move into the new system, you will see Massachusetts cases coming back online as we move to serology, because that allows them to capture the cases, but focus their personnel time on things that can try and prevent people from getting ill.
Okay. So last question here. Given the incidence, this is for Dr. Mead, given the incidence and geographic risk of Lyme is not static, but changing as tick habitats spread due to a variety of factors, how does the CDC monitor this? It goes on to say, it seems important to inform physicians in states that are seeing increased incidence to allow tick-borne disease into the differential diagnosis. The current schema of the CDC surveillance seems to limit or restrict tracking of expansion of risk and contracting disease. I guess, this is one question that I kind of always had too for some states that are, I would say, coming online to the Lyme epidemic more rigorously. What I always think of Michigan as an example, right? They have tick-borne disease coming from the west, from Minnesota and Wisconsin, and then coming from the east in Pennsylvania, Ohio. So you kind of imagine that over the next 5, 10, 20 years, they're going to be a much higher incidence. And so they need to be thinking about Lyme disease in that differential diagnosis. So I'll pass it over to you, Dr. Mead.
Yeah, absolutely. It's a good question. It's a good point. I guess I would answer that in two ways. First off, I'd note that, a lot of the issues about surveillance of high incidence versus low incidence states, that has been, in many ways, the way the system has been set up for quite some time. And in spite of that, it has, in fact, been possible to track the expansion of Lyme disease. I think the notion that it would prevent us from seeing that is not borne out by the past 20 years, where we in fact have seen that expansion. But the other way that we're working with states to address that is by looking at ticks. And so through our cooperative agreements with state health departments and through something called ARBOMET, we have been trying to get states to look for ticks in areas and to test those ticks in areas so that we start to get a better sense of what's going on from the tick side of it, where the abundance is going up and where the infection prevalence is going up. And we actually see a pretty good correlation between where we're seeing it emerging in humans and emerging in ticks as well. So we are looking at multiple surveillance systems to try and address that. And I think, again, at the end of my presentation, I mentioned there are several others that we're looking at that we're trying to bring online in terms of electronic health records and other things, all of which is to address this question. How do we track how it spreads over time and in space so that we can inform providers to think of Lyme and to really think of it early and get patients treated early so that they don't end up with problems down the line.
Well, thank you guys so much. Really appreciate your time today during the Q&A as well as the recorded session. And then also just the time and effort you guys put in your daily work to addressing these Lyme and tick-borne disease. So thank you very much.
Well, thank you, and Stephen and Alexander Cohen Foundation for this event, for everything you're doing.
Great. So I guess I'll just move into some closing remarks for the day. First, I want to thank all of the panelists and the participants for your time. I hope we were successful today, bringing you useful updates on clinical and research initiatives. Personally, I know how hard it is to keep lifting yourself up and lifting your loved ones up after heartbreaking medical disappointments. I think Megan O'Rourke said it well. It's hard living in a body at the edge of medical knowledge, but there is hope. There are so many people trying to solve this problem and so many people fighting for better access to care. At the Stephen Alexander Cohen Foundation, we are unrelenting in our drive to develop better diagnostics and a cure for this quiet epidemic crippling families across the US and the world. So thank you for tuning in and spending a few hours with us. All the videos and the Q&A will be available on LymeMIND.org in the next week or so. And again, I hope you have a great weekend. Thanks.